Thank you very much for your kind invitation, and thanks a lot for the introduction, and thanks a lot for the kind invitation. Great pleasure to be here, and it's great that we have a whole symposium or conference here on joint pain, because as you know, Serge Perot and myself, we are heading the global year against the joint pain under the RSP. And this year we have had a lot of activities around the world, so this conference is a very important event. And we developed, together with many other colleagues around the world, different fact sheets. They've been translated into 16 different languages. And actually, those of you who are going to the International Association for the Study of Pain meeting in Yokohama next week, there will be a book released. It will just be in time for the meeting. And actually, yesterday evening, we managed to get that book finally translated also into Japanese. So if any Japanese around you can read it, as Serge said. So, and then also the Pain Clinical Updates has actually featured various articles about joint pain and aspects related to joint surgery over the year. So there has been a lot of material released during this year. So we are very pleased for all the help to get this global year up and running. So what I'll do, I will talk a little bit about some of the techniques which we have available. I have not been asked to talk very much about the various mechanisms, but more a little bit about what can we do in the lab, what can we do in the clinic in order to evaluate the pain reactions associated with the joint or the surrounding tissues around the joint. And this sensitization phenomenon has popped up several times this morning, and again, just to highlight, and I think Tony already hinted to that, it's not something which is specifically related to joint pain. It's something which is specifically related to lots of pain conditions, which is going on for a long time with a certain high intensity. And I think this is very important to keep in mind, because there are a lot of common denominators for some of these phenomena and the things we can actually measure and evaluate in many of those patients. But of course, OA, RA, neuropathic pain from that point of view are conditions where we see these manifestations very clearly. But of course, we need to have different tools in order to tease it out, because it's different if you have central sensitization or sensitization related to a visceral pain condition as compared to a condition which is associated with, for example, a joint. So I'll go through that a little bit later here. And there are actually, again, as I said, some common features. And it seems that the intensity as such is really driving the development of sensitization, the duration, the years or the months, the patients who have actually had the pain. And then there's another feature which I think is actually important, and that's the number of comorbidities, or the number of additional conditions which are painful, because that's also contributing to the entire experience of pain. So 1 + 1 is actually 3. Because of that central integration of all the nociceptive activities. And if we have this sensitization, also very often what we see is that the pain areas mapped by the patients on different devices is actually also expanding. And at the end of the day, we may end up with having more or less like a widespread pain phenomenon. So these are some of the features which we can see across many of these chronic pain conditions. But what are the common mechanisms driving some of this progression of sensitization? For example, in young kids, with juvenile idiopathic arthritis, if those kids are being tested in a standardized way by very standardized test procedures, we will see that even at a young age, the various parameters such as pressure, cold pain, heat pain, those kids, they actually have lowered thresholds, indicating that they already at that stage do have some degree of sensitization. And one can imagine what is happening if you already do have these phenomena of sensitization in a very young age. What will happen as you grow up? What will happen when you get older? What will happen when you get additional pain problems on top of what you already have? We think that this is going to be even worse. So these are some of the techniques which I'll briefly go through. I'll just give a few slides on each of them. Different ways of assessing joint pain. a little bit about the association with some of the clinical parameters or the serological parameters. So this is kind of the agenda. So a little bit of it, can we actually evaluate pain from the joint itself? And there are not really many studies. There's, I think, maybe only one study where you actually try to poke the intra-articular tissues during an arthroscopic procedure and try to evaluate where do you actually generate the pain from. And we heard that the cartilage is aneural, avascular, at least under normal condition. Under pathophysiological condition, there may be, various changes. But this is just under normal conditions. And you can see that there are areas where if you just simply poke the areas, you can generate a lot of pain. And there are areas where you do not really generate a lot of pain. But this is under normal conditions. So what's happening in patients with osteoarthritis or rheumatoid arthritis, of course, we don't know. But there seems to be ways of doing it. And there's, as far as I know, only one study so far. If we apply some additional pressure or thermal or whatever extraarticularly, what will then happen? That's a little bit more easy. It's easy to apply. We can just use the thumb, or we can use some other devices where we can actually measure how much pressure we apply. And if we do that and we apply the pressure to a muscle or to a joint, we will see that in those patients who have inflammation, who have sensitization, who have different phenomenon going on, we will see that these thresholds are actually lower. So we can put on numbers so we can actually evaluate how much lower is it and what's happening before and after treatment, before and after surgery, before and after whatever intervention we can think of. So it's definitely possible to assess something which is at least is related to reactions when we apply pressure, again, extra-articularly. So we do not really know, of course, what kind of structures are we actually activating. But we know we can do and we can generate some maps if we apply pressure to many different locations. So if we apply pressure to a number of locations and we take and measure those pressure pain thresholds and we can overlay them on some MRI scans, we can start to get at least a feeling or an impression of where about do we have this pressure pain hypersensitivity. And again, we do not know exactly what we activate, but we do get different pain maps when we do this in different patient populations, for example, osteoarthritis. So there will be red areas where you have a low pressure pain threshold, as compared to controls where you will have more or less like a homogeneous pain reaction, so high threshold, not specific localized area with lots of hyper sensitivity to, for example, pressure. So we can now use this kind of technique in order to subgroup or at least look at different groups of patients. And if we do that, we can see that there may be specific patterns related to different clinical features. If we associate with the ongoing clinical pain, actually we see that there is a strong relationship, and I think I mentioned that already, that the ongoing pain intensity seems to be a driver for some of these phenomena. So we generally, under these conditions, see that the high pain intensity patients with OA, they are more red in a way, so they have more pressure pain hypersensitivity. And if we then start to correlate and associate with the actual joint damage, we don't see the same association. We already heard that. The structural damage may not associate very well with the actual pain. And it's not associated very well with these pressure pain sensitivity maps which we can actually evaluate. And again, we do not activate interarticular joint structures properly, interarticular structures, but we activate something at least related to this sensitization process. But there's very little association with the actual damage. So what about synovitis? We heard a little bit about synovitis. We heard a little bit about different subgroups. But for example, if we take those groups as we saw before from the Finland study, those are the high pain, low damage. And we also found that those patients are showing a very, very particular pattern. And they seem to be highly sensitive, just as sensitive as those with high pain and high damage. So this seems to be a subgroup of patients probably responding differently to different interventions. We don't know, but I think at least it's interesting that we can start to separate and we can find out there are if there are different subgroups of patients. So OA is not kind of one, in a way, general disease. I mean, there may be many, many subgroups, and this may be one way of separating some of them into a specific group. So, as I said, synovitis may be another feature, because we heard that the synovitis in general is associated with a degree of pain. Can we evaluate synovitis? We don't know, but at least we can try to apply pressure to patients with different degrees of synovitis. And how do we evaluate the degree of synovitis? I mean, again, there are many different ways. What we use some special MRI scans where you do contrast, and we evaluate the extent of synovitis based on that kind of procedure. And if we do that, we do not find very much association between this synovitis or the development of synovitis as assessed by this technique and the pressure pain threshold. So what we can see on the MRI scans may not, at least for this test, associate very well with the sensitization which we can actually assess. So again, there's something additional adding to the equation here. So we found an association between the pressure pain and the ongoing pain, but we didn't find very much association between this measure of synovitis based on MRI scans and the pressure pain and the actual pain rating. So again, there are some features which we do not really understand, but definitely we can evaluate and define specific subgroups of patients. So what's now happening if we apply stimulation or external stimulation to another extrasegmental site? We heard that the generalized sensitization will actually eventually activate and sensitize the entire body extrasegmentally to where you actually do have your joint pain problem. So if we do that, and there are many studies on that, and there's kind of a consensus now that some of those patients with severe pain for a long time, they actually develop generalized hypersensitivity to many different stimulation modalities, pressure, heat, or cold, or different stimulations. You can see that OA patients in general are much more sensitive to those different painful stimulations. So there seems to be a consensus that this generalized hypersensitivity is present, at least in those later stage patients. And if we apply pressure again to either the arm or to the lower leg, again we will see that the OA patients, they have significantly lower pressure pain thresholds. And actually, if we start to correlate with the degree of ongoing clinical pain, although it's a scatter diagram, but there is this overall association, which we have seen in many, many conditions. So I think it's kind of established more or less now also under many different conditions that the ongoing pain is actually also triggering parts of this spreading sensitization. So we can actually evaluate and assess that again quantitatively, see again what's happening after treatment, will we normalize, or what will happen with these different reactions. So this we have already seen, but OA is not one only condition showing abnormal patterns when you inject something into the muscles. All the other chronic musculoskeletal pain conditions are also showing abnormal patterns. And it seems that the more widespread as such the condition is, the more widespread pain patterns we also generate experimentally. So there seems to be this association between how much do the patient actually experience of the body covered by, in a way, pain, and these experimentally applied provocation tests. So, what's happening in the brain? We heard about that. I've just taken this example, and we heard a little bit before, where we can see that those patients who are more in the neuropathic area of this pain detect, although we are not absolutely sure that this pain detect is reflecting anything related to neuropathic pain. There have been several studies by David Walls and others recently showing that there's not very much association with some of the other neuropathic pain scales. So I'm not sure that the pain detect questionnaire will detect anything associated with neuropathic pain, but it may detect a specific group of patients having some symptoms which may be of importance. At least we know that those with with high degree or high pain detect scores, I mean, they have more PAG activation. And the PAG, as you know, is involved in some of the excitatory descending inhibitory, or deciding in some of the descending facilitatory pathways, but may also, to some degree, be involved in some of the inhibitory pathways. But nevertheless, those patients with high pain detect scores, they have more activity in that specific region of the brain. So, as we heard before, there are some objective measures that something is happening also, at least in the brain in the patients who are experiencing this pain. So, biomechanically, what can we do? And this is something which is a little out of the scope here, but I thought that it would be interesting just to add it, because it's something which we can do in the lab. It's something which we can do to the patients. And I just give you one example that we can actually give some insoles into the shoes of the patients, and we can actually see how they distribute the forces during gait. And we see very specific differences in patterns in patients as compared to controls. And we can actually see what's happening after, for example, surgery. Do we actually normalize some of these patterns, et cetera, et cetera. So it's just a new tool. And what we figured out was that there is even an association between the degree of pain sensitization and some of these, what we could call biomechanical patterns. So the more abnormal this biomechanical pattern is, the more sensitive are those patients to a specific pressure stimulus. So there seems to be maybe some association with some of these biomechanical parameters, which may be a tool which we can also use in the future. So, as we heard, sometimes the knee joint replacement will alleviate pain, but unfortunately, in 15-17% of the patients, they will still experience pain after an otherwise technically successful knee replacement. So what is the reason and what's happening in those patients? And I think this is important for us to understand and to get a better understanding of some of the features driving this transition or this maintenance of the chronic condition. So in a recent study we saw that 15%, approximately 14% of the patients, they will still experience pain 12 months after an otherwise technical, successful knee replacement. So why is it that those patients, they separate from those who are actually more or less pain-free after the surgery? And we know that there are quite a number of patients experiencing pain after such joint surgery. And I think one thing which we should really keep in mind, and that is there was a recent survey in US showing that there would be a 7-fold increase in number of joint replacements up to 2030. So, and if 15% of those patients continue to have pain after an otherwise technical successful knee replacement, then I think we're going to have a very big problem. So if we could identify parameters which at least could give us a hint of who are those vulnerable patients, and secondly, are there anything we can do in order to minimize the chances of developing chronic pain, I think this would be a really great thing to look into. So somehow we need to identify those patients one way or the other. So if we look at the patients who have had a successful knee replacement with no residual pain, we saw some of these slides before, they have more or less a normalization of these both localized and these kind of spreading pain phenomenon, which is fine. But if you continue to have pain, actually this is just a schematic figure, but we will, in many of those patients, we will see more sensitization. And actually some of them, they end up having more pain after the surgical procedure. So why is it that they will continue to have pain? Why is it they will even continue to have more sensitization? And then the scariest thing here is that those who have actually a revision surgery based on the indication pain, I mean, it's okay if the screws are falling out and things are not optimal, but I mean in those patients who have revision surgery based on the indication pain, when we look into those patients, we will see that things are often going even worse. 85% of those patients are actually ending up having more pain than they had initially. And if we look at them and we screen them and we monitor them and we measure different reactions, we see that they are even now more sensitized and they have even more pain. So again, there need to be some red flags, there need to be some indicators whether this is a good way to go or whether there should be any other interventions, one way or the other, to interact with this. So this is just a simple measure which can be done very easily. And we have other indicators, as Tony told you about this morning, this integration or this central integration, which is another feature. So in patients, we have a strong facilitated central integration if we apply repeated stimuli to the patients. They will have a facilitated response to such repeated input. But again, if we have a successful knee replacement, no pain after surgery, they will get normalized, which is good news. So the pain system can reset. Control-Alt-Delete, we will get a resetting of the system, which is fine. The facilitation will go back and come back to the normal situation. But in those patients having pain after surgery, they will, as I said, many of those will have more pain, and if we look at it again, they will even have more and a stronger facilitation of the temporal summation. And those patients who actually will have a revision surgery and will continue to have pain after the revision surgery, they will have even a further facilitation of this central integrative mechanism, indicating that the central nervous system is still in a hyperexcitable stage, and somehow we need to bring that down to a more normal condition. So the final thing which is important, and we just heard a little bit about it also this morning, is this descending inhibitory control. So there are different ways of doing it in the lab or in the clinic. I don't want to go into it, but we can measure it. And we heard that this will be reset after successful knee replacement. This impaired descending inhibition, we know this is a battle between facilitation and inhibition, but nevertheless, this battle will be finished, and we will have a normalization of this descending inhibition. Fine, it's good. But in those patients having pain after surgery, we will have still an impaired descending inhibition, and sometimes we will even have a further increase in that deficit of the inhibition. And in those patients who have pain after the revision surgery, again, this system is even more attenuated and the system is even more disturbed, and we even have more problems with the brain in order to control and keep the pain under control. So again, there's this transition from one to another, and it's very consistent across all these measures, which we can actually do in the laboratory. And if we map patients with the pain, where they have no pain after knee replacement, sometimes they have a little bit here and there, it doesn't matter, but those who have pain after revision surgery, you can see that they start to have many more locations where they experience a pain, and it's changing into more widespread pain condition. We have had patients, look at patients now who have had 5 revision surgeries, and they have pain all over the place. They do have widespread pain syndrome. So I think this is something which is slowly changing due to these various interventions. So fundamentally, can we then subgroup these patients? And I don't have the full answer, but I think that there is a pattern which starts to appear. We may have a group out here who are very pro-nociceptive. We may have a group out here who do have a normal functioning system. This may not be the case for patients with chronic pain, but they may be maybe somewhere around here. But those patients out here are those who have high pain. They have lots of catastrophizing. I haven't touched about that. We know this is also an important feature. They may have local, very low, reduced pressure pain thresholds, both locally and at other extrasegmental sites. They may need a very little input in order to generate temporal integration. And they may have actually even a facilitated descending inhibitory control system. Those patients we know are highly vulnerable also, and those are also the ones most likely to develop chronic postoperative pain after knee replacements. We have shown that in several studies. And if you move along here, we would expect that you get less and less, in a way, pro-nociceptive. You may get in a better and better, in a way, condition. So this is somehow the pattern which is slowly starting to appear. So I'm not talk very much about this, but I mean, there have been some indications now that there may be some serological parameters which may associate with some of these experimental pain parameters. But we have done lots of studies on it, and honestly speaking, I think it's very, very difficult to find very robust association between serological biochemical biomarkers. So what we can start to do now, we can start to map and we can start to actually profile patients with different, what we could say, different OA subgroups of patients. And these are just different groups. I'll not go into all these details, but these are all different measures which we can do, which have to do, some of them have to do with what I already showed. But we have identified now that there are specific groups of OA patients, and absolutely sure that they will respond differently to treatment. They will actually, many of those respond also different to surgery. So I think it's important to start to get this understanding of subgroups of patients, not only OA, but also RA, as we also touched upon this morning. So in conclusion, I think we can say that the joint pain is actually projecting as a local sensitization, but also this kind of spreading sensitization. We can quantify it by different measures. I think it's important to realize that there are different subgroups. We are starting to get more and more information about that. I think it will have impact on the treatment regimes which are being used. The joint replacement is fortunately most likely successful, but in those patients it's not successful. It may end up causing more sensitization, and those who have revision, they may end up having even more pain and more sensitization. So I think predicting or profiling patients may actually help predicting outcome of treatment, but it may also help predicting outcome of surgery if we get sufficiently detailed information involving a lot of different parameters, not only what I have described today. So thanks to all my collaborators back home, and thank you very much for your attention.